Good afternoon, ladies and gentlemen. At the outset, I'd like to thank Dr. Khanna for providing me with this opportunity to be present here amongst this august audience. Most of them are my colleagues and some of them are my teachers in the past. I have been entrusted with the task of initiating this session on aortic interventions, and quite rightly so. It was to begin where it should begin, with epidemiology and natural history of aortic aneurysms and dissections. This was a statement given by Sir William Osler around 100 years ago, and we know how right he was when he said that there's no disease more conducive to clinical humility than aneurysm of the aorta. So, beginning where we should begin, aortic aneurysm is a permanent localized dilatation of aorta and its branches. More than 50% of normal. There is a certain amount of debate about this definition also, but it is now accepted that anteroposterior diameter of any segment of aorta more than 3 centimeters in both genders is to be considered as aneurysmal. It is anteroposterior diameter, let me stress. For the sake of this particular discussion, which will be focused on natural history and epidemiology, I would like to divide the aneurysms into thoracic aortic aneurysms and abdominal aortic aneurysms. We'll see the reasons later on. But they have been also been classified in the past as true aneurysms and false aneurysms, fusiform aneurysms versus saccular aneurysms. And the aortic dissection is defined, as you all know, as a breach in the intima leading to a tear in the media, which may tear again or may continue like that. So starting with the epidemiology of thoracic aortic aneurysms. They're quite different. Not all the aneurysms of the aorta are the same. It is not one topic, it is quite heterogeneous. So I'll be discussing them one by one. In thoracic aortic aneurysms, the distribution is as shown in the diagram. The most commonly seen in ascending aorta, 60% of the thoracic aneurysms begin in ascending aorta. Next is the descending thoracic aorta, which has around 40%. Then comes the arch, and thoraco-abdominal aneurysms constitute around 10% of the total thoracic aortic aneurysms. The etiology of thoracic aortic aneurysms is quite different from that of the abdominal aortic aneurysms. The most common cause of thoracic aortic aneurysms is cystic medial necrosis, which is degeneration of the media, replacement by a cystic myxomatous tissue, and even in Marfan's disease, connective tissue disorders, familial cases, and even in bicuspid aortic valve, this is considered to be the final common pathway, which results in the weakening of the media and ultimately formation of aneurysm. Atherosclerosis, hypertension, increasing age, and aortitis is, of course, these are the other causes, but most common being cystic medial necrosis. The association with bicuspid valve is quite strong. Almost 50% of cases of even normally functioning bicuspid cases have dilatation of the aorta reaching aneurysmal extents. Familial cases have been reported recently in the literature, and genetic and familial causes are now becoming one of the most common causes of ascending aortic aneurysms. While the etiology in arch is usually similar as an extension of the causes of ascending aortic aneurysm, descending thoracic aorta, the cause of aneurysm is mainly atherosclerotic. The reasons are not very clear at this moment, and aortitis is also one of the common causes of aneurysm in descending thoracic aorta. Now, the natural history of thoracic aortic aneurysms again is quite different from that in abdominal aneurysms. They of course undergo progressive enlargement until they increase in size and ultimately they rupture. So thoracic aneurysms means there's an adage which says that aneurysm begets aneurysm. And when you are looking at an aneurysm, you are looking at something which is going to rupture in the future. So the rate of growth for thoracic aneurysms is 0.1 centimeters per year. It depends also on size. Increase the size at the time of detection, the increase is the rate of growth, of course, because of the Laplace law. It says that the higher the diameter, the increase the wall stress, and increased is the rate of growth of the aneurysm. Location also has a role. We'll see later on how it influences the rate of growth of aneurysms. And in patients with Marfan syndrome, the rate is much higher than what is seen in aneurysms associated with other causes. The aneurysms ultimately may go dissection or rupture. The incidence of dissection also depends on the underlying size. The higher the size, the greater the chances of dissection and rupture. And interestingly, although women less commonly have aneurysms, but when they do have, the tendency to rupture is higher than that seen in males. And this is one of the reasons when now it is being proposed that in case of women, aneurysms should be intervened at an earlier age because the tendency to rupture is higher as compared to males. The mortality when the aneurysm ruptures is very, very high. It is 54% at 6 hours, 76% at 28 hours within the first day, and of the 13% patients who survive, if they are operated upon, operative mortality is around 46%. The majority of aneurysms are asymptomatic. So this is one of the most disastrous combination we can have. Something having such a malignant history remains asymptomatic unless detected by chance. Most of the thoracic aneurysms have been picked up by chance, and there are case series illustrating that more than 95% of aneurysms have been detected only when they ruptured. Rarely they may present themselves with compressive symptoms, compression of trachea, presence of Horner syndrome, SVC syndrome, or thromboembolic phenomena.
I request the audience to kindly maintain silence, please. It is disrespect to the speaker. If you have any conversation to make, please go outside and make it. Kindly maintain silence. Gentlemen on the left, I am requesting you to please maintain silence. Please carry on.
Thank you, sir. This is a beautiful case report which came in the New England Journal of Medicine, and it illustrates very nicely the natural history of an aortic aneurysm in which we failed to intervene. This was a 74 years old gentleman who had malignancy of stomach associated with hypertension. He was diagnosed to have a thoracic aortic aneurysm of around 5.6 centimeters in diameter. He refused intervention. He was followed up regularly. You can see the increases in size of the thoracic aneurysm till eventually it ruptured at an age of around 84 years. The patient could not be saved. So this is the natural history, very beautifully illustrated by this single patient of thoracic aortic aneurysm. If we don't intervene, this is the ultimate prognosis. 1 year survival of untreated aortic thoracic aneurysms is around 39 to 52% depending on the etiologies, the age at which it is detected and interventions, while the 5-year survival is only 13 to 19%. Out here I'd like to highlight that when we talk of coronary artery disease, and there's much hullabaloo about coronary artery disease all the time, and Framingham risk score is used to classify high risk patient in which the 10-year mortality is 20%. And here's a disease in which 5-year survival is just 19%. So this is a very, very high risk condition. It should be detected as early as possible and intervention appropriately done at the opportune time. Coming to the epidemiology of abdominal aortic aneurysm, these are the commonest type of aneurysm, more common than the thoracic aortic aneurysms and have attracted more attention. Infrarenal, there is a classification, suprarenal versus infrarenal. Infrarenal is more common as compared to suprarenal. Prevalence is more common in men as compared to women. It increases with age. But quite interestingly, there occurs a rapid spurt in the incidence after the age of 55 years in men and 70 years in women. Overall, there has been noted that there is an increased incidence of abdominal aortic aneurysms in the recent times. It is believed that it is due to increased screening being done. And secondly, the other factor is that perhaps we are increasingly doing more and more CT scans of the abdomen on which abdominal aortic aneurysms are incidentally picked up more commonly than they were in the past. Racial factors also appear to be responsible, and in a few studies where ethnic populations have been studied, it has been found that the incidence of aortic aneurysms in abdomen was less common in Asians as compared to Hispanics and whites, but it is conjectural at the moment. The incidence of abdominal aortic aneurysm is depending on the several factors and is enumerated earlier, hence the different data that we have regarding the incidences. In autopsy subjects over 50 years of age who were studied in Norway, because there's a small place where autopsy is done on almost all deaths, they came around with an incidence of 2 to 4% over an age of 50 years. If we see men over 60 years, the incidence is 5 to 10%. In patients who have coexisting peripheral vascular disease, the risk of having an associated abdominal aneurysm is higher. Here's the familial incidence. If you have a first degree relative, especially a brother, a male first degree relative with aortic aneurysm, your chances of having an aneurysm is 20 to 25%. And in patients with femoropopliteal aneurysms, the chances are that you have associated aneurysms at other sites, specifically in aorta, abdominal aorta, is 35 to 40%. So this underscores the importance of suspecting aortic aneurysms in these population subsets, looking for them and screening for them, and hence you can appropriately treat them.
Dr. Mehrotra, the time allotted to you is over. Please try and sum up.
The risk factors for abdominal aortic aneurysms are different than those of thoracic. Smoking, age, hypertension, atherosclerotic risk factors being the most common factors. But interestingly, diabetes is a negative risk factor, does not contribute to abdominal aortic aneurysms. The natural history is similar, except that the rate of growth is higher as compared to thoracic aortic aneurysm. They enlarge rapidly as compared to thoracic aneurysm, 0.4 centimeter per year. And then, of course, they undergo dissection and rupture. The mortality rate is 25% before reaching a hospital, and 50% patients have died in the hospital waiting for surgery. Most of the aneurysms, of course, are asymptomatic. Coming to the epidemiology and natural history of aortic dissection, there's this classification, proximal versus distal, which is also important because of the natural history, which is quite different. The treatment patterns for the two types is entirely different. But aortic dissections are uncommon. Importantly, if they do occur, the mortality is very, very high, at the tune of 1% per hour.
Please come to the conclusion.
Right.
I think we'll skip the dissection part because it's very important and you'll take another 5-10 minutes, which is not fair on the other speakers.
Okay.
I think we'll skip the dissection, and we appreciate the talk you have given on aortic aneurysms. Let's give him a big hand, ladies and gentlemen. So although epidemiology and history is considered not so an interesting and boring topic, but if we fail to take lessons from history, we'll continue to commit the same mistakes that we've been committing time and again. This is the photograph of a gentleman, Albert Einstein, who succumbed to abdominal aortic aneurysm rupture at the ripe age of 76. Any questions?